Picture this. It's 6 a.m., you're at conference, presenting a patient with let's say, a tricky melanoma on their back. The questions start flying. What are the margins? Are you doing a sentinel node biopsy? What if it's positive? And suddenly, the room just freezes. Don't worry, I'm here to walk you through exactly how a safe, high-yield surgeon thinks. Okay, let's dive in. Here's my promise to you. By the end of this, you're going to be able to look at any melanoma, read the two most important words on the path report, that's depth and ulceration, and just automatically generate the correct plan for the biopsy, for the margins, for the sentinel lymph node biopsy, and for the referral. We are turning that gut-wrenching uncertainty into a rock-solid algorithm. And here's our roadmap. We'll start with the basics. Who gets melanoma and why? Then we'll get into translating that pathology report into a real plan. After that, we'll lock in the surgical margin rules. Those are non-negotiable. Then we're going to tackle the massive paradigm shift in how we manage the nodal basin. And finally, we'll cover advanced therapy and surveillance before we lock it all in with some pearls and practice questions. Okay, first up, risk and biology. Before we can even think about treating this disease, we have to understand it. Figuring out who's at risk and how this cancer even develops, well, that's the foundation for our entire management plan.
Now, this is what's so wild and honestly pretty sobering. Melanoma makes up less than 5% of all skin cancers, but it's the one that causes the vast majority of deaths. And to make things worse, its incidence is climbing. The stakes are incredibly high, which is exactly why we have to get the management right from the very beginning.
So who's most at risk? I want you to think of it like this: risk wheel. At the top, the biggest slice is UV exposure. We're talking about those intermittent, blistering sunburns you got as a kid. Next up is phenotype: fair skin, light eyes, red or blonde hair. Then you've got genetics. About 10% of cases are familial, and CDKN2A is the big gene you have to know for your boards. After that, precursor lesions, like having a ton of moles. And finally, immunosuppression, which just lets the disease be more aggressive. So how does this actually happen on a molecular level? Well, think of it as the mutation ladder. It's a step-by-step process. It often kicks off with a BRAF V600E mutation in a totally benign mole. And this is huge, because that's the same mutation we can target later with specific drugs. As it gets worse, it picks up more hits, like TERT activation, which basically makes the cells immortal. Then it loses a tumor suppressor like CDKN2A, and boom, it's melanoma in situ. And the final step? Losing gatekeepers like PTN allows it to invade deep and metastasize. It's literally a ladder of genetic mistakes. For your exams, you absolutely have to know a couple of these genes by name. CDKN2A, which codes for the P16 protein, is the most common high-risk mutation they'll test you on. And here's a critical pearl. Families with this mutation aren't just at risk for melanoma. They're also at a much higher risk for pancreatic cancer. BAP1 is the other one to keep on your radar. All right, so we've got the biology down. Let's move on. We're now at the absolute core of our algorithm: staging and diagnosis. This is where we take that piece of paper from the pathologist and turn it into a concrete surgical plan. So let me ask you directly, when you get that pathology report back, what are the two features, the two words that are going to dictate literally everything you do next? The whole plan hinges on these two details. If you said Breslow depth and ulceration, you're spot on. This table right here is your cheat sheet. Look at T1A. It's super thin, less than 0.8 millimeters, no ulceration. Your action plan is simple: 1 centimeter margin, no sentinel node biopsy. But watch this. Look at T1B. The depth just creeps up to 0.8 millimeters, or you see ulceration. Now, all of a sudden, you have to consider a sentinel node biopsy. And once you cross that 1 millimeter mark, you're in T2 territory, and you absolutely have to offer one. It's all right there. Depth and ulceration drive everything. So how do we get this critical info? With the right biopsy, of course. The gold standard is a full-thickness excisional biopsy. That means 1 to 3 millimeter margins, and you're going all the way down to the fat. On an arm or a leg, you have to orient it longitudinally, up and down the limb, to preserve the lymphatic drainage for a potential node biopsy later. And here's the biggest exam trap: a superficial shave biopsy. It is dangerous. Why? Because you can cut right through the bottom of the tumor, making it totally impossible to measure the true Breslow depth. Okay, now that we have our diagnosis and we have our stage, let's talk about the definitive local treatment. These are these surgical margin rules. They are rigid, they are highly testable, and you gotta get them right every single time.
You just have to burn these numbers into your brain. For melanoma in situ, it's 0.5 centimeter to 1 centimeter. For any invasive melanoma up to 1 millimeter deep, it's a 1 centimeter margin, period. If it's over 2 millimeters deep, it's a 2 centimeter margin. And for that group in between, 1 to 2 centimeters is fine. Here's the key takeaway. Margins greater than 2 centimeters have been proven to provide absolutely no survival benefit. So please don't pick 3 centimeters on an exam.
Okay, we've managed the primary tumor. Let's move on to the nodal basin. And folks, this is where one of the biggest paradigm shifts in all of surgical oncology has happened in the last decade. Seriously, what we do for positive nodes has completely changed.
So first, who even gets a sentinel lymph node biopsy? It all comes down to risk. For T1A lesions, the risk of having a positive node is so low, less than 5%, that we just don't do it. For T1B, that risk climbs into the 5–10% range, so that's a discussion with the patient. But for any tumor thicker than 1 millimeter, that's T2 and up, the risk is over 10%, and a sentinel lymph node biopsy should absolutely be offered. Now for the million-dollar question. You've done the wide excision, you've done the sentinel node biopsy. The path report comes back, the sentinel node is positive for metastatic melanoma. Your attending turns to you in conference and asks, okay, what's next? For decades, the answer was automatic. But it's not anymore.
The answer changed because of two landmark trials, MSLT2 and DECOG. They took patients with a positive sentinel node and randomized them. Half got an immediate completion lymph node dissection, that means taking out all the rest of the nodes. The other half just got simple observation with serial ultrasounds. And what did they find? Well, taking out all the nodes gave better local control, sure, but it gave absolutely zero benefit in melanoma-specific survival, and it came at a huge cost, a staggering 24% rate of lymphedema, compared to just 6% with observation. So let me say this as clearly as I can. For a microscopically positive sentinel node, the standard of care is no longer a completion lymph node dissection. It is nodal observation with serial ultrasound, followed by a referral to medical oncology. This is a massive, practice-changing takeaway. Now, that leads us perfectly into our next section. Once the surgery's done, our job isn't over. We have to know when to refer for advanced therapies and exactly how to follow these patients for the long haul. So what happens if the patient presents with nodes you can actually feel, clinically palpable stage 3 disease? Well, the old way was to rush to the OR, take out all the nodes, and then give therapy afterward. But the recent SWOG S1801 trial just flipped this whole thing on its head. It showed that giving neoadjuvant immunotherapy, in this case pembrolizumab, before surgery significantly improved event-free survival. The new standard is immunotherapy first, then surgery. And how do we follow these patients? Well, every single patient needs lifelong dermatology skin exams. For the first 2 to 3 years, when the risk of recurrence is highest, they need a history and physical with their surgeon or oncologist every 3 to 6 months. Now, what about scans? We reserve CT or PET scans for patients with higher risk disease, think stage IB and up, or for anyone who starts developing new symptoms. We've built the entire algorithm from biopsy to surveillance. Now, let's lock it all in with a final review of the most critical, high-yield facts that you are pretty much guaranteed to see on your exam. Okay, let's do a rapid-fire recap. The critical depth cutoff between T1A and T1B is 0.8 millimeters. Never, ever use margins greater than 2 centimeters. For those thin T1 lesions, an adverse feature, like a high mitotic rate, should push you to discuss a sentinel node biopsy. A positive sentinel node does not equal a completion lymph node dissection anymore. And palpable nodes mean neoadjuvant immunotherapy, not upfront surgery. Got it? Let's finish with a classic board-style question that puts it all together. A patient has a 2.5 millimeter melanoma, and their sentinel node biopsy comes back positive. Staging scans are all clear. So what is the standard of care for that nodal basin? Well, based on everything we've just covered, you know the answer isn't B, and it's definitely not A anymore. The MSLT2 trial data proves the standard of care is C, observation with serial ultrasound. You've absolutely got this.